Good morning. Welcome to Grand Rounds, Pediatric Grand Rounds. We have a guest speaker this week, Dr. John Gordon. John comes to us from Prince Edward Island in Canada. So he's traveled quite a distance to give our Grand Rounds. I invited him as he was one of my mentors in training. John did his own medical training and pediatric training at McGill University and Montreal Children's Hospital. I worked with him at University of Maryland where I did my training. He was, I think, the first one to identify I might be an intensivist when I got quite flustered and angry at him for ordering something on my child while I was at lunch one day as an intern in the ICU. And he sort of teased me about that throughout the rest of my training. I did work with him in his lab with pulmonary hypertension, where we worked with a sheep model, and he's also been known to work with pigs, and I think I did make you a plethoric pig cake one time. But taught me all sorts of things about oscillator use and nitric oxide and lots of interesting things. He left University of Maryland after I completed my training and completed his working career at the University of Wisconsin, the Milwaukee Children's Hospital, and is here to talk to us today about a special needs clinic he developed while he was there that we thought would be very interesting for our group to hear about. Whether we might be able to pursue something like this, we're not sure, but we wanted to hear more information about it.
Great. Thank you. Thanks very much. For the record, I was in Milwaukee and not in Madison, so I was at the Medical College of Wisconsin and not University of Wisconsin. University of Wisconsin is the wrong guys. Anyway, thank you very much for inviting me, and thanks Janie and Vicki for your help in making this happen. I actually spent until this past June, I was at the Medical College at Children's Hospital of Wisconsin in Milwaukee, and retired then, so that's why I'm in Edward Island now. And I should have brought a picture on the map, but it sits north of New Brunswick and west of Nova Scotia. And, it's a great spot, vacation. It's a pleasure to come and talk to you about our complex care program. Mary McCord, who is a pediatrician who I worked with, made the clever observation that all complex care is local, just like all politics are local. And so I'm hoping that the stuff I will describe may not be what exactly you would imagine for here, but the ideas behind providing care for medically complex kids are somewhat the same. Turn your volume a little bit. Oh, okay. Can you hear me now? I can hear you. So I have no disclosures, as will become really evident. This is a money-losing proposition. I will discuss some of the work that came from various grants. Our most important one was a Healthcare Innovation Award from CMMI, and they require that I tell you that these are my ideas and not theirs, and that they're not responsible for anything I say. I would like to begin by acknowledging my colleagues in the special needs program in Milwaukee. The leadership of my medical school and my hospital who supported our program, our collaborators with the Healthcare Innovation Award, who are at the Department of Health Services or Medicaid in Wisconsin, and American Family Children's Hospital in Madison. That's the University of Wisconsin, which we work closely and aren't really our enemies. And then my complex care colleagues everywhere. Most importantly, thanks to the families and the kids who have taught me so much and have contributed so much to developing our program. So what I'm going to do is briefly talk about children with medical complexity, then talk about the first 11, 12 years of our program when we sort of were feeling our way towards how to deliver care for these children with medical complexity. Then I'll talk a bit about our Healthcare Innovation Award, which falls in the category of be careful what you wish for. We got a $9.5 million award to massively increase the program in a 3-year period, and this was a real challenge. And then talk a little bit about the future directions, which are more the future directions of my successors than of mine. So who are we talking about? Children with medical complexity are a relatively poorly defined population with many names. They're known on hospital wards and ICUs often as frequent flyers. We call them children with special health care needs with high resource use. The term children with medical complexity was coined by A.L. Cohen in Toronto, along with Agarwal and Berry and a few of the other real movers and shakers, a younger group of complexologists who came up with this sort of definition of the kids with chronic severe conditions crossing many specialties. They have functional limitations. They're technology dependent. There's often neurologic impairment. One of the high marks of is their very high tertiary center and other healthcare use, and they have high costs. Most of you would know who I'm talking about when you see them, and you probably can imagine children with medical complexity. So the impact on these kids on healthcare systems, there is an increasing population according to most research, and they have really high costs. Tamara Simon wrote a paper back in 2010 showing that children with one or more complex conditions were 10% of admissions, 26% of hospital days, and 40% of charges. And I think this was in 2 states using Medicaid data. We looked at kids who had 3 chronic conditions, 2 unplanned admissions over 10 days. That accounted for only 0.4% of the kids followed at Children's Hospital, Wisconsin. It accounted for 21% of inpatient days and 17% of payments to the hospital. So they're an expensive and high user group. I always credit Bob Miller here, who is a general pediatrician, a highly respected general pediatrician, who got lured into becoming the chief medical officer at Children's Hospital of Wisconsin. And he developed a bee in his bonnet about the idea that there were these kids who were complex, had uncoordinated and siloed care, and felt this contributed to their frequent readmissions. You know, these are the kids who the cardiologist wants to do one thing, the pulmonologist wants to do another thing, the nephrologist wants to do another thing. The intensivists change every week. I can guess the intensivist because I was invited by one. His thought was if we could make this somewhat less siloed care, that there might be less admissions. The other thing was that the lack of communication amongst people really irritated families, and primary care docs did not like the fact that they would enter the unit and they would then be spat out 3 months later, and there wouldn't be much communication during that time. So what we did was we combined 2 small nurse care coordination programs. They added me. I was an intensivist at the time and was interested in moving out after 20 years to do something else. And we then sought input from various key stakeholders, including the families and the primary care docs, the specialists and administrative leaders at our institution, and then some insurers. So families say that these kids need tertiary center services. They need access and availability 24/7 because they're often sick and admitted. They need continuity of care and providers who know the child and the family goals. They also need home and community services, medical services, school, recreation, fun. A lot of the parents emphasize the fact that we rarely thought about the fact that these kids, when they're not sick, want to have fun, and then they need insurance and benefits. The families themselves say that they wanted coordinated care with good communication. They wanted a go-to person or team familiar with the goals. They wanted recognition of their role in care, and they wanted assistance in goal setting, transitions, and future plans. The essential services, when we at one point had gotten the program going for a few years, and then 2 of the docs left and the parents gathered for a meeting with us, we invited 5, 17 showed up because word of mouth went around, and they announced that they thought it was great if we cut back our services to just 24/7 availability, being there for ER visits, doing rounds on the inpatients, having clinic visits, and maintaining care plans for kids. Interestingly, the families don't tell Santa that, if you look closely, could be me, about their own needs. And as I'll describe a bit later, these families really are heroic in their care of these kids. So how do you meet these needs of the families and the kids? Well, a primary-centered medical home should be the answer. It's got everything that it says. The definition of a primary-centered home care, centered medical home is what they need. And the primary care docs that work in our community really wanted to do it, but there is really little time and resources for doing this. Most offices don't have the infrastructure of a care coordinator or a nurse is capable of spending an hour on the phone with families every day. And it's really poorly reimbursed. There isn't a code for spending a lot of time talking to a family. So what they said was they could do it, but they needed help with communication, managing unusual conditions, looking after, ordering meds that they'd never heard of, and coordination of the care amongst the different specialties. The tertiary center care coordination programs have been growing in the past 15 years or so, and they're ideal in terms of access to tertiary center resources because you're there. We could lie in wait and capture the gastroenterologist as he was walking down the hallway from the cafeteria. He used to hide, at least one of them did. But the problem is that they would like to do it as well, but there isn't the time and there isn't resources within different specialties. And it's somewhat inefficient use of their time. For a neurologist to spend an hour and a half coordinating some home care issue that's somewhat outside of their area of their specialty, rather than spending the hour and a half reading EEGs, it's just not useful use of their time. So they said they needed help with communication amongst the team, managing multiple chronic conditions, coordinating care across the continuum. Other stakeholders that are key to the care of children with medical complexity include the community services such as schools, therapies, pharmacies, nursing. They all want to help. They're all somewhat intimidated by these kids, and they're all amazed at the medical maze. And so they asked for a single point of contact within the hospital so that they could call up and say, so-and-so is having a problem. Can you find me the person to deal with this? The payers and the insurers included the insurers and the healthcare institutions because the insurers didn't pay very much. So our hospital and our medical school paid for it. And the mantra is they want to do the right thing. They'd like to help the families. They'd like to provide better care. They'd like to get the kids home more often and stuff. But they wanted some, if they were going to pay, they wanted some evidence of return on investment. They wanted value measures, and they wanted us to really be fiscally responsible. So what we did was we decided that the approach that we should take is to partner with children with medical complexity and their families and all of these other key stakeholders to ensure seamless in- and outpatient care. Our mantra was that this was family-driven, family-centered care that involved familiarity with the child's condition and the goals, the family's goals of care, availability of 24/7 coverage, continuity at home, in the community, in the hospital. Flexibility was essential. The primary care docs, the specialists, and the families all had different ideas of how involved they wanted us to be. Everybody said, we want you to do everything except sending them to us for routine visits. And others said, I'll one of the gastroenterologists, chop off your hand the next time you order TPN on my patient, And so it was, we had to become flexible, and it added time and effort to what we were doing, but it turned out to be a useful way of working with everybody. And then finally, accountability. We collected and disseminated data, and we tried hard to reduce our costs and make some money. So one of the first questions we asked was who should we follow? And the considerations included who could we have some impact on, and what did we know what to do? Well, I was an intensivist. Two of the nurses had been recovery room nurses, and one of the nurses had been in charge of spina bifida and CF, and so we were all pretty hospital-based, and we were all pretty intensive care-based. So it was easy to make the leap of saying, let's take kids who are really complicated and spend a lot of time in the unit. The other thing was that, coming back to this idea that this 0.4% of the kids followed accounted for 20% of the admissions, that seemed like a good target group. So we established complexity criteria that said to get into the program, kids had to have chronic conditions involving 3 organ systems and requiring 5 major specialties. Fragility was 2 or more admissions for 10 or more days, or 20 or more clinic visits during the prior year. We also considered some social determinants, such as foster care, distance from the center, poverty, but those were not primary reasons for getting into the program. Exclusion criteria included the fact that needs were met by another program. For example, if the child was followed by the trach vent program and all of the needs were met, we didn't have to be involved. If the child was followed by trach vent program, but their major issues were cardiology, neurology, and GI, then we would get involved to help coordinate multiple groups. We did not enroll any kids whose families did not want the service. We would get referrals from Child Protection Services saying, you know, we want this child in your program so that you can make them do such and such. And we were no better at making people do anything than anyone else. And it seemed sort of silly to spend a lot of effort on families who didn't want this.
Complexity and fragility?
Yes. Yeah, no. Yeah, sorry. For enrollment, we take referrals from anybody, including the families. The referrals were reviewed weekly. There was a sort of triage by our intake staff. Then there was a sit-down meeting at which we discussed the patient. If they met criteria, we would see them in a 90-minute initial appointment. There was a medical review, review of their coordination needs and the goals of care. And then we would decide, should they be in the program? And sometimes the family would say, you know, turns out I really don't need what you're offering. Sometimes we would say, geez, they looked complex on paper, but in fact everything's under control. Sometimes, you know, say, oh, this would be better managed by trach vent, for example. So if criteria were met and there was no exclusion, they would be enrolled. After enrollment, the nurse, we had at the beginning, as I mentioned, nurse care coordinators and a physician. We added a few more physicians and then nurse practitioners, but the nurse care coordinator role provided some clinical services, as you can see. Perhaps most important were things like patient advocacy. Shortly after a child would be enrolled in the program, the nurses would attend cardiology appointment, pulmonary appointment, renal appointment, and be able to say to the cardiologist, pulmonologist, nephrologist, you know, Dr. So-and-so just said such and such in the appointment that we were just in before that, and that contradicts what you're saying, so we got to figure this out. And you can imagine some of the people at the beginning were not enamored with that program because they were sitting there and doing it. But, you know, we had one cardiologist escorted one of our nurses out of an appointment at the beginning, and 6 months later, he was a prime source of referrals to our program. So it took some time to demonstrate that we actually added value and helped people out, but we succeeded in doing that, I think. A lot of the nurses' time is spent being confidant to the families, somebody who the family can just call up and run stuff through without sort of feeling like they're burdening the system. And I think that's a large reason why we were able to get kids out of the hospital more quickly. The physicians and later nurse practitioners as well did medical co-management in the program. We didn't follow any children primarily. They all had a primary care doc, but we were their co-manager, whether they were in the hospital or at home. We did provide 24/7 call, and we would do ED consultations in person anytime during the day and by phone at night. And then we rounded every day. Initially, we had our own service, and then we went to a consulting model just because we couldn't do all of the different things. The other important thing was that there was no set rules that this is your job, this is my job. So if it was a weekend and somebody needed a feeding pump repaired and there was a doc on call and no nurse, then the doc called up the DME company and got this done. And similarly, you know, the nurses when we had a shortage of docs and nurses started taking first call for the phone calls at night. So, we grew over the years. We started out with 2 nurses and a clinical nurse specialist and a .5 MD, which was me. By 2008, we had 4 nurses and 3 docs, and we had gotten to about 200-ish patients as our peak census. Then in 2009, 2 of the docs left, and it was difficult, and we dropped down a little bit. That's when, after 2 years of recruiting for physicians, we added nurse practitioners because a couple of nurse practitioners came to me and said, you know, we could do this job. And I said, geez, I don't think so. And I'll show you later, they can do the job. They do the job easily as well as we do. What I'm trying to show in this slide mainly, though, is that we reached a plateau. It really didn't matter what number of personnel was. We got to this point where about 40 to 50 patients per nurse and a bit more of that per doc was the limit that you could follow with this high-intensity population. In terms of the patients we followed, this is just a sort of demographics slide. We had followed 630 patients at that point. They were a slight preponderance of males. They came in at a median age of 2.2. This was largely a reflection of the beginning. We took kids who were older, and then as the program aged, our age of enrollment got lower and lower because people would be referred to as younger and younger. The language and the ethnicity statistics sort of reflect our catchment area. With the Children's Hospital of Wisconsin, the 290-bed hospital, and it looks after most of southeastern Wisconsin and a bit of the rest of the state, some Iowa, northern Illinois. We had the majority of patients who were, or plurality of patients who were from within 25 miles, but a lot of patients lived further away than could be reasonably expected to be seen for routine care at Children's. There was a median of 5 organ systems for the kids in the program and 7 specialists. 73% of the kids had G or J tubes. We had 7% trach vent. Only 16% had no obvious technologies. 47% of kids had Medicaid as their only insurance, and 53% were private, but about 2/3 of the kids with private insurance also had Medicaid as secondary. So it ended up that we had 85% of our kids were Wisconsin Medicaid was their payer. In 2013, at the end of 2013, we had 183 patients enrolled. By that time, 75 kids had died over the prior 11 years. 93 withdrew. These are kids who just disappeared from the program, and we didn't know why they had left. A disturbing thing to us, because that was about 15% of our patients. We clearly weren't serving their need, and the rest had graduated. And that meant either had stabilized, had moved somewhere, had a transition to adult care. In terms of organ systems and specialties, GI was the most common organ system, and neurology was the other. And not surprising, GI and neurology, those specialties looked after a lot of the kids. Genetics was a very common subspecialist for us with a lot of syndromic. In terms of data that we collected, we developed a little family satisfaction survey, looked at a variety of different aspects of the care of the child, and satisfaction was basically really pretty high. This was on the Likert scale of 5, and we scored pretty well with everything except for future health, which was saying, have we helped you plan for what you're going to do for your child in the future, and transition of care to adult services. The transition of care to adult services, we are not unlike most places that just didn't have a very good system. And the future health, we had a hard time predicting what was going to happen with some of these kids. A lot of them had lived well beyond what anybody thought they were going to do. And you'd sort of sit there and say, geez, fibrosis and a hypoplastic left heart. He had a Fontan procedure done before his cystic fibrosis was appreciated. He's now, he'll be 18 in December, and he's chugging along, and you know, nobody thought he would be more than 3. So, PCP satisfaction is uniformly pretty high, and it's grown over the years. Of note, after adding the nurse practitioners, we were a little bit nervous with the PCP, but happy with nurse practitioners, and it turned out that they were equally happy with nurse practitioners, more happy with the fact that there was more access to providers. Children's Specialty Group is our specialist group at the Medical College and Children's Hospital, and I showed it. I showed the very satisfied, and I didn't like those numbers, so I also wanted to show the very satisfied and somewhat satisfied because it looks a whole lot different. The appointment availability was not so much in the availability of the program, it was availability of getting kids referred into the program. And there was great unhappiness with the fact that we were so restrictive in who we brought into the program. A lot of people wanted a lot more of their kids, and it would cause real irritation if somebody said, I've got a kid for you, and they said, well, we're not taking your kid. Well, see if we talk to you again. So, my wife is an MBA IT-type person, project management, and when I started showing all the satisfaction data, she said, yeah, who cares about that? Where's the beef? You know, so here's sort of the beef. This slide shows events per day pre-enrollment or post-enrollment, and this was just to allow a sort of simple pre-post statistical comparison. And you can see there's a significant increase in clinic visits. There's actually a statistically significant increase in emergency visits and short-stay visits after enrollment. I'll come back to that. There's a statistically significant decrease in admissions, but it's pretty trivial. The big change is in hospital days, where there's a marked decrease in hospital days. Children's hospital charges, children's hospital payments all went down. Showing that in aggregate for equal periods, pre- and post-enrollment, which allows comparison of days to days and dollars to dollars, you can see that there's about a 44% increase in clinic visits from about 9,500 to about 1,350. There's the emergency room visits and the short stay visits, as I say, are pretty flat pre and post. Hospital days go down by 48% from about 2,400 to about 1,400. Charges went down by about 70 million, and payments went down by about 25 million for 584 patients enrolled for a mean of 459 days or a median of 335 days. So there's a sort of striking difference. The medical college billed for physician fees, and their charges and payments showed a similar pattern. Pre-post data is fundamentally flawed, but it is what we had. It cannot prove that this is the intervention versus simply regression to the mean over time. But I would say that patients are only enrolled if they had continued high resource use anticipated. Patients who got better were discharged. The admission rate continued to be high, but hospital days went down, which I think indicated that we were able to decrease length of stay. And similar results have been seen in other programs. There's a guy named Mosquera in Texas who did a small randomized controlled trial and saw very similar data. So we think that had some effect. Since we were at a tertiary institution and a medical college, we were also supposed to do some research. It's interesting to me the change in complex care. In 2004, there were 5 presentations at Pediatric Academic Society meeting that could be termed complex care. In 2013, there was over 100 poster and platform sessions. Teaching, there's a guy named Tom Klitzner at Mattel and UCLA, who has been a driver in the whole area of education in complex care. Advocacy, the American special interest group in complex care, Children's Hospital Association, sorry about that spelling, Lucille Packard Foundation, and the Centers for Medicaid Medicare Innovation have all been driving progress in this field. David Bergman and Eyal Cohen are important people in thinking about models of complex care. Rita Mangione-Smith in Seattle has developed quality measures for looking after chronically ill kids. And then in the impact of complex care, Pat Casey, Jay Berry in Boston, and Dennis Kuo are all really strong investigators and clinicians in the field. I'm particularly proud that in our group, we decided that everybody should present. So our nurses all presented at meetings. We had two nurses did platform presentations at PAS, and it just turned out to be a real pleasing thing for members of the group to think that they could get up and talk about the program and do it at a scientific meeting. I've been mostly interested in programmatic and health services research thing. We're focused on quality improvement and then family-focused research looking at quality of life and looking at the impact of children having a child on families have been major interests of ours. We got a grant. The woman who is now the manager of our program was one of the nurses in the program, and just before we got that grant, she said, I do not know why you keep writing grants. You get so grumpy when you're writing the grant, and nobody can talk to you, and you never get one. And then we got the Maternal Child Grant for $900,000, and she has subsequently become an investigator in her own right. I think it's quite funny. Anyways, we got a grant, and the main thing that came out of that was we wanted to develop and implement a care coordination curriculum for families because it was really obvious we were only touching a small number of medically complex kids. There's a ton of them out there. And so we developed this curriculum. The key people on that was Holly Colby, who was the initial manager of the program and my co-founder of the program. Simone Conceição, who is a professor of education at the University of Wisconsin in Milwaukee. Sarah, who is our research coordinator, and then Ann Yeoman, who is the mom of two kids with mitochondrial disease and was a nurse herself and had this passion for teaching. So the curriculum includes 12 modules. Each one of them is identically structured of sort of what's the problem, how do you do it, and then we developed some writable PDFs that go with it. It's available in English and Spanish, and anybody who wants to see it, you're more than welcome to it. It's on Children's website, or you can email me and I can send it to you. It was quite useful. The problem, of course, is that the people for whom it would be most useful had the least amount of time to go through it and fill out the stuff. And the people for whom it would be least useful said, well, why bother doing this? So it's a really good curriculum, but it's not the right platform. We're now thinking of some sort of an electronic thing might be better. So we had some successes between 2002 and 2013. Some of it was planning, a lot of it was luck. We had very engaged stakeholders who helped us develop the program. There was high satisfaction. The impactable population led to impressive pre-post data, recognizing that that's not necessarily proof. And we worked hard on addressing the goals and the needs of the various stakeholders. But whether this was sustainable was still a question. Our finances by 2013, this, as I said, was a labor-intensive and time-consuming work. It's poorly reimbursed. Our expenses were about $1.1 million for the medical college, that's the providers, about $600,000 for the nurses, about $80,000 for operating expenses, and our revenues were about $336,000 for fee-for-service, and we got about $100,000 from Medicaid for care coordination fees. So we ran a deficit of $1.3 million, which neither Children's nor the medical college was really ecstatic about. My approach was Powerball. I never won. So the problem for thinking about growth and sustainability was that everybody wanted us to look after more kids, but we were stagnant at about 200. How could we increase things? One approach would be to increase caseloads, which was not a real favorite with anybody. And the other was to increase personnel, which was not a favorite with the institution. So what was clear was that we had to control costs, we had to continue to demonstrate value to the stakeholders, and we had to recruit and retain personnel. It's hard to find people who want to do this work. It's sort of like palliative care, except it just goes on. And so the burnout possibilities are really big. So just around then, CMMI came out with the second round of the Healthcare Innovation Award, RFA, and Wisconsin Department of Health, which is Medicaid, proposed that we apply for a round 2 care coordination award because they really liked our program and they wanted to see it grow around the state. We wanted to become sustainable and so needed to do some things to get to there. And American Family Children's Hospital wanted to start a program in Madison. So the state sort of saw this as a win. They said, let's get Children's to lead this thing, bring American Family Children in, and the state would support it and be the PI on the grant. So we submitted it, and with these goals of expanding the population that we look after. To do that, we dropped the number of specialists to 3, and we went from 2 admissions for 10 or more days to 1 admission for 5 or more days, and then 10 to 10-plus clinic visits. The target census that we set for ourselves was 1,860 patients at Children's and 300 at American Family Children's. And what the state promised in return was that they would work on developing a sustainable payment model so that we would not be such a drain on our respective institutions. The triple aim mantra was the aim for the thing. Of the various things that we did with the grant, probably the most useful was develop this care coordination assistant role. This was done by Tara Bartelt. She's the current manager who did research in the past, but she developed this whole idea and developed the training for them, the competencies, everything. And the idea was to get some lay coordinators to be part of the thing, to do the work that didn't really require a nurse care coordinator, getting patients to clinic. One of our care coordination assistants got somebody a new home through Habitat for Humanity. You know, I mean, just a lot of the social determinant stuff was done there, and our hope was that this would free up nurses' time and allow them to get to higher caseloads than 40 or 50 patients. And that really did work. The other thing that we did was expanded the nurse practitioner role. We went from 2.2 nurses to nurse practitioners to 6.6. And this just to illustrate to those who want to be or might be interested in this, is that work our views in this kind of work, which is talk intensive and action not so intensive, are pretty low. But the nurse practitioners have a higher work RVU rate and almost as high a charges rate as the physicians in the program. The other thing is that they're 95% clinical and 5% doing QI type work, and they had lower salaries. So it was a way of really expanding the program very effectively while containing costs. We did reach a sort of breaking point at some points where when we got to four nurse practitioners and I was the only physician, this was too many nurse practitioners for one physician to adequately supervise, but it was pretty good. The unsuccessful innovation was this idea of getting to 1,800 patients in 3 years. We had come up with this hypothesis that we would divide the program into 2 sections. One would be the moderately high user group, and the other would be our traditional high user group. And it was going to be, it was beautiful on paper. I wrote it, and it was just perfect. Recruitment of new people was slow. New people couldn't start a new program. It two separate models. And the other problem was that patients, just because they don't use the hospital a lot, didn't reduce their complexity. Everybody had the same complexity criteria for getting into the program. And when we looked at the amount of time a high user versus a moderately high user took, it was a trivial difference. You know, in the first 6 months, they took about the same amount of time. And so, you know, this was a bad problem that led to us not being able to meet our enrollment targets. And the enrollment targets were important. I mean, one of them was that this was a major goal of the grant, and the other was that we needed an end to figure out a payment model for the program. On the other hand, the larger caseloads with new staff, we were afraid it would decrease satisfaction, it would lessen the impact of the program, and it would really negatively affect recruitment and retention. I mean, there was a lot of unhappiness as the numbers grew and the personnel didn't. So happily, the CMMI group favors a plan, do, study, act approach to these grants, which is really sort of unique in grant world. So we sort of presented the data to Wisconsin DHS. They looked at it, they presented it to CMS, and it was agreed that we just had to go with a smaller target numbers, and they recognized the flaws of the design and that it was good to change it. So with that, we've been fairly successful. We got to, now it's somewhere around 1,100 or 1,200 kids. The grant ended September 1st, so I don't have the last 6 months included here, but we did get closer to the targets, but it was clear that we were never going to have 2,100 kids in this program, that there's going to be somewhere around 13 or 1400 kids in this program to happily, the satisfaction data remains good. These are just one general question: how satisfied are you with the special needs program? And this was just from our institution. And you know, there was the bulk of respondents were very satisfied, and the bulk said they would recommend the program to other parents. Primary care docs, the numbers were a bit lower. I think we hired people out of surveys. We were surveying all sorts of different things. But again, the vast majority of primary care docs were still very satisfied with the program. And there was less complaints about the fact that they couldn't refer kids to the program. Pre-post data, again, with all of its flaws, the overall, this includes our very high users, the high users. It doesn't include our NICU grad, which was another group that we included, because the NICU grads really just, I mean, it totally skews the data because they have gazillion dollars before they come into the program because they've just been in the NICU. So, but there's a significant decrease in costs, and you can see the major drop in utilization is, this is the percent of the money going to inpatient service goes from 66% to about 35%. The other percentages go up a bit, but combined with the drop in total costs, they're really pretty close to flat in terms of absolute dollars. In terms of the payment model that we initially proposed that we would come up with a per member per month care coordination fee. This was not a risk idea. This is a fee for the members, not a per member per month overall payment. And a shared savings plan. It was anticipated when we wrote the grant that this would take more than 3 years. And so what the state said was that they would come up with an interim plan to sustain the program until we could come up with a final plan. And this was done on a lot of faith. You know, it was a letter from DHS saying, we will do this. And the institution, to their credit, and American Families Children, hired a lot of people with this promise of something to come, and DHS has lived up to it. We collected a lot of budget and patient and staff time data and have developed with Milliman, an actuarial firm working for the state, and the state has come up with 2 fees, one of them for enrollment and one of them for ongoing care coordination. The ongoing care coordination is a monthly per member per month coordination fee. the initial enrollment fee is a single fee, and they rolled the whole team into it. Rather than having a doctor fee and a nurse practitioner fee, they said, we will pay the institution somewhere in the neighborhood of $1,100 for enrolling a patient, and somewhere in the neighborhood of $450. These are under review by CMS now, so the final numbers are not going to be there. But this is going to be enough to sustain the program. We will still likely run a deficit, but we are allowed to still bill for our face-to-face services, and we can provide other services. So the program is going to go from running a $1.3 million deficit with about 200 patients to running somewhere closer to $300,000 or $400,000 deficit and having 700 or 800 patients. So it really has been a worthwhile, I think, experiment with the state in developing this. The state also wants to try and bring some of the private payers to the table and pay for some of this care coordination, because that 15% of kids that don't have Wisconsin Medicaid, we don't get any care. So for the future, there's this hope of developing an all-in care coordination co-management fee. To that end, we've got to somehow come up with a better measure of cost savings than pre-post analysis. Health measures are very difficult. In the adult world, you know, if you hemoglobin A1C isn't such and your lipid level isn't such, but then you don't get paid. Health measures, value measures in the population are really hard to come up with. Quality measures are equally hard to come up with. On the one hand, you can say they can be process things. Did we get the care note done? Did we do this? Did we do that? Those are process things, but an actual quality outcome of this was improved. I would love to see the quality outcome be, did we meet the goals that you set for your child, which I think would actually mean something, but structuring that is going to be a challenge. We have to continue to measure our data. And then the question is, this is great in a system where Medicaid is the payer and the hospital is the provider of the medical. You know, does it work in an ACO? And I would argue, yes, it does, because if this program actually saves the institution money by reducing hospital days, then it shouldn't really matter whether it's an ACO or it's getting paid fee for service. The field, I think, is ripe for all sorts of research. The needs of children with medical complexity and their families is barely scratched. You know, the inclusion of some of the mental health and social determinants in trying to figure out how to help these families, as well as looking after their medical needs, is open for research. Education and family education and training and resiliency. There are families who you've all seen who, you know, there doesn't matter what hits them, they just bounce right back. And there's other families that, you know, the littlest things cause catastrophe. And is there a way of learning what makes a family resilient and sharing that with families who aren't? It would be really interesting. Best practices in complex care. I think it's hard to come up with best practices until we better define the population. It's and we get more data, but I think that would be the future. And the final thing is strategies for developing expanding complex care. Several of us want to write a paper or a monograph that says, so you want a complex care program, and just try and share the experiences of the different types of complex care programs. And I think it's kind of fun. We keep talking about it. We've been talking about it for several years now. So hopefully, now that I'm retired, I'll draft something. But anyway, thank you for your attention. I just stuck up here the names of the people who are involved in the program right now, as well as my own. If anybody wants to get hold of me, feel free. And that's the other members of the team. Thanks.
Questions in the room? Questions or comments? All right.
you think there's a minimum number of patients you need to make this worthwhile?
You know, I think, no. You got to find somebody to look after them. So there's a minimum. If you've got a small number of patients, when we started the program, in the first year, we got to about 83 kids. Medicaid took the data from those 83 kids and started a program called Healthcare Connection, where they paid us $100 a month for the doctor's time and $100 a month for the nurse's time, based on cost savings shown with 27 of the kids. So, I mean, there was striking. If you choose if the denominator of your population is really high users, then you can demonstrate a statistically significant, again, pre-post with its flaws, effect. The problem with a really small number of kids is that you then have a really small number of providers, you know, 1 or 2 nurses, 1 physician, you know, a part of a physician, a part of a nurse practitioner. You know, the nurses are invaluable for the care coordination component because with this population, because they can do a medical triage assessment, whereas a lay coordinator would not be sort of allowed to do that. So you would be talking about, in my thinking, a nurse, part of a physician, part of a nurse practitioner. Sharing call for this population. There are some centers which have said everybody takes call in a hospitalist group or something, and there's a subset who are really not interested in doing that, and it really doesn't work if you're not invested in doing it. So you have to find a willing group of intensivists who will do it. When we dropped to 1 doc, my backup was several of the intensivists covered when I would go away or need a night off. So I think you can demonstrate value with a small number.
And do you feel like you impacted or that families had more realistic expectations when they worked with you?
So I think it is a trajectory. I don't know if you've ever seen any of the stuff that Chris Feutner, who's a ethicist, palliative care guy at CHOP, has written, but he talks about the sort of the spectrum of palliative care being from cure-seeking to comfort-seeking. And I think that our program is very similar to that, with perhaps a bit more emphasis on the cure-seeking at the beginning in particular, but in most cases, you know, it does get to a comfort thing. So I think that we are able to help families come to a realization, but that really is a long road with some of the families. I mean, there are some families who really want their child to have a diagnosis, and then they want them to have something magical that's going to cure them. And it takes a long time to get to the point of saying, you know, this is what I have, and let's make this as good as it can be. So we talk a lot about, doesn't matter what we find out. In the meantime, let's make it as good as it can be. So that's long-winded, but
not an easy answer.
Any other questions?
Thank you. It's very interesting. As a physician running the program or the nurse practitioners, how much of what you did was hands-on care versus coordinating the subspecialists and sort of figuring out which subspecialist needs to see the patient for that problem, if their PCPs were still involved?
That's a good question, and it, I've got a similarly vague answer. I think it varied when it was. When the child first comes into the program, it's very hands-on. I mean, there's a lot of time spent trying to figure out what exactly is going on, because you know, a fair number of the kids were mito or other unusual diagnoses that nobody had unusual symptom complexes that nobody had really put their finger on what's wrong with them. And so spent a lot of time sort of going through what their tests were and stuff, and then talking to the different specialists. We undoubtedly added 2 or 3 specialists to most kids once they came into the program, even if it was just for a single visit to sort of say, okay, you really should see a geneticist, and they, you know, do whatever they do. When the kids were fully, so maybe describe what we did. You know, we got to the point with before the grant, we had an average inpatient census of about 8 or 9 patients on our service. They're now running about 25. So we now have 2 nurse practitioners and 1 of the docs on the inpatient service all the time, because we round on all of the kids, try to round with the team. The families think that if we're not there, there isn't progress towards discharge. There's, you know, with acute management in the ICU, you know, you would be astounded, but I don't tell people what to do. You know, and I don't write the orders. But once the child's through the critical thing, a lot of our time is spent trying to get the child to discharge, because, you know, it's just not you know, somebody said, you know, your next priority in the ICU is not a child being discharged. Your next priority is the next child who's critically ill. And on any given day, I suspect I spent 1 to 2 hours just doing paperwork, stuff related to that child. So it was sort of the end of every day. You get back, and there's PAs, there's letters of medical necessity, there's a discussion with Dr. So-and-so, there's a care conference and stuff. So probably 2 hours a day doing that. Probably 2 or 3 hours a day was directly with the patient, and the rest of the time is just frittered away.
I'm curious about the 24/7 coverage of the service and how that overlapped with what the PCP was doing. So why would they call you instead of the PCP?
That's a good question. So it again, it's evolved, and families got really good, and the PCPs appreciated this, that if a family thought this was something that was likely to need the hospital, they would call us. If the families thought this was something that the PCP was going to be happy to deal with, they would call the PCP, particularly the families that lived far away. You know, they would typically call. If it was something that looked urgent, so that the family was going to call 911, they would call us and say, little Johnny's doing such and such, we're calling 911. We would call the local ER, who, if this was a child who had frequent problems, they would sort of know us, and they would know the family. But we would call them and say, so-and-so's coming in, this is the standard thing. If it looks like they're going to need to come down to Children's, call me back, and we'll arrange the transport. So that was sort of our role. Oftentimes, you know, if it was what was considered by the family to be a routine childhood illness, or if it was something that the PCP had said they were happy to manage, then the family would call them. But it was more often if it looked like they might need tertiary care, or if it was something that they were sufficiently complicated that they wanted us involved, then they would call us.
I think we are out of time. We've got actually 40 people on the line, so I hate that we're not going to let them talk, but we are continuing this conversation at 11 with a conference line and another webcast, I believe, or some, not the same presentation, but we're having some, no? Informal, yeah, that's, okay. Well, if you're interested in being on a phone call, hearing what we have to say, there might be a potential that you could do that. With that, thank you very much.
Thank you.
Okay, if you're on the line, sorry I ran out of time for questions, but you can email us at outreach@CarillionClinic.org, and we can get them to Dr. Gordon. With that, we're going to disconnect the phone lines now. Thank you all very much.